Dear colleagues, welcome to this OncoAlert session roundup during ASH24. Today's roundup is on multiple myeloma, focusing on advanced minimal residual disease, or MRD. This is on detection, impact on prognosis, and treatment decisions. We start off with the phase 3 GMM-GHD7 trial, impact of MRD on PFS in newly diagnosed multiple myeloma patients with isatuximab, lenalidomide, bortezomib, and dexamethasone induction therapy. The GMM-GHD7 phase 3 trial investigated the impact of adding the anti-CD38 monoclonal antibody isatuximab to the standard RVd regimen, lenalidomide, bortezomib, and dexamethasone for transplant-eligible patients with newly diagnosed multiple myeloma. The study demonstrated that Isa-RVd significantly increased minimal residual disease negativity rates compared to RVd alone, with MRD negativity achieved by 50% of Isa-RVd patients versus 36% in the RVd group after induction therapy. Landmark analysis showed that MRD negativity status post-induction and post-intensification was associated with significantly longer PFS with Isa-RVd, yielding better outcomes in MRD-positive patients. While PFS was similar between Isa-RVd and RVd in MRD-negative patients, the addition of Isa-RVd provided a significant advantage in those with persistent RVd positivity. At a median follow-up of 48 months, the trial further demonstrated that patients who achieve MRD negativity after induction or post-transplant had significantly better PFS outcomes compared to those with MRD positivity. Isa-RVd benefit was evident in MRD-positive patients, showing prolonged PFS compared to RVd alone. GMM-GHD7 is the first phase 3 study to confirm that a rapid and deep MRD negativity response with an 18-week induction regimen can provide long-term benefits even without additional consolidation therapy post-transplant. Future analysis will contribute to evaluate the effects of maintenance therapy with or without isatuximab, further isolating the contributions of isatuximab to patient outcomes. We follow up with our second trial, implications of MRD progression in newly diagnosed multiple myeloma treated with quadruple therapy and autologous stem cell transplantation. This study explored the implications of minimal residual disease progression, MRDP, in patients with newly diagnosed multiple myeloma, treated with quadruple therapy and autologous stem cell transplantation. The findings revealed that MRDP was relatively uncommon, but its presence indicated an eminent progression in IMWG-defined disease progression. Importantly, patients with MRDP had similar clinical outcomes to those with disease progression not preceded by MRDP, including shorter time to progression and poor survival free from failure of second-line therapy. The study underscores that MRDP in this context is driven by a growing plasma cell population that is unlikely to respond to current therapies, including monoclonal antibody-based regimens. Despite many patients being on observation at the time of MRDP and some initiating therapy with monoclonal antibody-containing combinations, the progression occurred rapidly. The research challenges the traditional approach of defining disease progression solely based on paraprotein levels and highlights the need for new markers and therapeutic strategies in responding to rising MRD, particularly in high-risk populations. These results call for a reconsideration of the current definitions of progression and the deployment of agents with new mechanisms of action in future clinical trials. The CEPHEUS phase 3 study demonstrated that the combination of daratumumab with bortezomib, lenalidomide, and dexamethasone, or DVRd, significantly enhanced minimal residual disease negativity and progression-free survival in transplant-ineligible or transplant-deferred patients with newly diagnosed multiple myeloma. The study found that DVRd achieved higher MRD negativity rates compared to VRd, both at 10 to 5 and 10 to 6 sensitivity thresholds, with sustained MRD negativity being significantly more frequent in the DVRd group. This deeper response translated into a significant superior PFS for DVRd versus VRd, with over 80% of MRD-negative patients remaining progression-free at 54 months. These findings underscore the efficacy of DVRd in improving long-term outcomes for transplant-ineligible patients and transplant-defer newly diagnosed multiple myeloma patients. In addition to achieving deeper MRD responses, the addition of DARA to VRd also resulted in improved PFS, with continued benefits observed across from MRD-negative and MRD-positive patients. The study showed a clear and sustained benefit for DVRd in both the depth and duration of response, with higher rates of MRD negativity and sustained MRD negativity at all pre-specified time points. These results seem to support the use of DVRd as a new standard of care for transplant-ineligible patients or transplant-deferred patients with newly diagnosed multiple myeloma, adding to the growing body of evidence that incorporates daratumumab into first-line therapy for better clinical outcomes. The study's findings are consistent with other phase 3 trials demonstrating the benefit of DARA in combination with standard of care regimens for newly diagnosed multiple myeloma. The final presentation we cover is a prospective cohort study. Sustained MRD negativity for 3 years can guide discontinuation of lenalidomide maintenance after autologous stem cell transplantation in multiple myeloma. Autologous stem cell transplantation followed by lenalidomide maintenance remains the standard of care for patients with newly diagnosed multiple myeloma, with maintenance therapy typically continuing until disease progression. In this study, patients who achieved sustained minimal residual disease negativity through next-generation flow cytometry and imaging after 3 years of lenalidomide maintenance were allowed to discontinue treatment. MRD testing was conducted every 6 months to monitor for early relapse, and lenalidomide was restarted for those who converted from MRD negative to positive or experienced relapse. Of the 194 patients included in the study, 26.3% achieved sustained MRD negativity and discontinued maintenance after 3 years, with a median follow-up of 32 months post-discontinuation. The results showed that a high percentage of patients remained MRD negative for up to 30 months after discontinuing lenalidomide, with only 23% converting to MRD positive and a small number progressing to active disease. Among those who restarted lenalidomide after MRD positivity, the median time to progression was 9.5 months. The overall progression-free survival was 74 months, and 1 patient died due to unrelated causes. These findings suggest that a sustained MRD negativity could serve as a reliable biomarker to guide lenalidomide discontinuation after autologous stem cell transplantation, although prospective clinical trials are necessary to confirm these results. Reinitiation of lenalidomide in patients with MRD positivity may help delay disease progression. And that's it for this wrap-up. Thank you for your attention and hope you enjoy ASH24.